Super.
Okay, so because this is recorded and will go into our website, I want to formally welcome everybody to the Health Design Network Cafe, recommencing our series that was interrupted for a few months. And we are going to begin, thanks to Gianpaolo Fusari, that is our guest speaker today. And then we will plan other meetings starting in September. But these meetings are not formal conferences of the sort where people get into some kind of contest to be able to come here. It's just a group of friends that believe in the same kinds of things that design could do in the health sector. And the intention when we founded it was to have a forum where we can exchange ideas, experiences, and thoughts and get richer as time goes by. Not richer in money, but richer in knowledge, in wisdom, in mindsets, in life. So you know that because I send you the information, Gianpaolo is an industrial designer with extensive experience in the health sector. And we are curious about the opportunity to talk with you, Gianpaolo, to see what is exactly that you're doing, what are the things that you really like that you're doing, and learn a bit in the process. So the screen is yours.
Thank you, Jorge, and also thank you to Guillermina for the invitation. We've met back in December in Switzerland in the Swiss Design Network Symposium, and we were lucky enough, I guess, to sit together during the meal, during a lunch, and yeah, we just started talking, and yeah, it was a nice connection to make. So thank you for the invitation. Yeah, so I've prepared a few slides that explain a little bit about what we do at the Helix Centre, which is this place where I work at here in London. And hopefully through those, you get a sense of what we do and how we use design in our practice. So yeah, is it okay for me to share?
I just made you host, so you have the power of sharing the screen.
Bear with me, because this is Zoom and it's one of those that I don't use very often. All right.
Yeah, okay.
Here we go. Are you able to see my screen?
Yeah.
Okay, so if I do then this, are you able to see that full screen now?
Yeah.
Nice. Okay. Right. So I'll explain a little bit about the Helix Center and how it came about, but basically we've been going on for a little over 10 years. And so this presentation talks a little bit about those lessons that we've learned in this time since we've been active. And it's just a little bit of a reflection of how we fit design in this health and academic research context. My official title at Helix is Head of Products and Platforms. And that means that basically I look after a team of designers and developers at the point when we are already producing solutions. So once we've finished doing prototypes, or actually understanding the context, having a brief, creating prototypes, and taking things a little bit further, that's when the development team and the development process kicks in. So I lead that side of things. Right, so very quickly, just my background. As Jorge said, I'm an industrial designer, so I was trained in industrial design. I did a master's in industrial design engineering at the RCA. And after graduating from the RCA, a little after that, I became involved in design and healthcare. Actually, let me go back a little bit more. So before I studied industrial design, I went to medical school, actually. So I studied medicine or pre-medicine for 1 year, realized that it wasn't a career path for me, and then changed to design. So I've been always interested in how things work, making things. that kind of stuff. That drew me into design. My dad was an engineer, my mom is an architect, so there was a little bit of that. But I think I went to medical school because my dad said, I always wanted to be a doctor, so why don't you try that? Obviously, did not work. But the interesting thing is that I went full circle. So after doing design, I had the opportunity to become involved in design for health, and I haven't changed since that. So yeah, probably started in 2011 around that time. So it's some time. Some of the projects that I've been involved in are quite a wide range. From service design projects like the one here bottom left, reducing violence and aggression in A&E, to transportation and redesigning an emergency ambulance for the NHS, all the way to more product industrial design type projects in developing surgical processes and instrumentation for total knee replacement for Johnson and Johnson, or GP bag. So we did a home visit bag for primary care as well. So that was pre-Helix, before I joined Helix Center. Yeah, Jorge.
Paolo, I have a question on the go.
Yeah.
What is A&E?
Oh, sorry about that. Accident and emergency. So it's the emergency department, basically.
Okay. Okay. And TKA?
Total knee arthroscopy, but it's like total knee replacement. Yeah.
Okay. Okay. Thank you.
Sorry about that.
No
NHS is
problem.
National Health Service as well. So, there might be a few acronyms here and there, but yeah, please feel free to jump in if I don't notice them. Yeah. All right. So that takes me to the Helix Center, which a little bit of background. It's an innovation hub that started as an initiative from the Royal College of Art and Imperial College, with the idea of bringing designers, which is the expertise, or design leadership is the expertise of the Royal College of Art, and combine that with the expertise of Imperial, which is science, technology, and medicine, bring that together and place it in the front line. So we're based at Imperial College Healthcare Trust at St. Mary's Hospital. So we're inside the hospital. And that is, at the time, maybe 11 years ago when we started, it was very unique. It wasn't very common to have a design studio inside a hospital. There were some initiatives here and there. I think the Mayo Clinic comes to mind. I think Kaiser Permanente also had a design team somewhere in there. But I think the difference with our group was that we're not serving the trust or the hospital. We obviously work with them, but our projects and our remit goes beyond that. And we truly think that we tackle global health problems through our local point of view as well. So this is sort of our mission. So we design and evaluate products and services that tackle major health challenges, and very importantly, putting people and their needs at the center of what we do. We also do some education in methods, design methods for others as well. But I think that putting the people at the center, so being user-led, is the core of what we are trying to do at Helix. As I said, we're based in St. Mary's Hospital, which is one of the busiest areas in London. So it's a very, very concurred hospital. On the bottom left picture, you can see that's when one of the royal babies was born. So the royals come here to give birth. And so, yeah, it's quite trafficked hospital. It is also the birthplace of penicillin. This is where Alexander Fleming discovered penicillin back in the 1800s. And so, yeah, quite a bustling area of London. We are part of a larger set of centers. So our mothership is called the Institute of Global Health Innovation. And this is led by, our co-directors are Professor Ara Darzi, who's the chap on the right, and Professor David Navarro on the left. And our team is very multidisciplinary, as you could imagine. The leadership being with Prof. Darcy and Leila Shepherd, who is a doctor in electronics engineering, but has vast experience in developing new technologies and implementing them in the, as startups, but also in the NHS. So she was part of NHS Digital and was very involved in the launching of the NHS app as well. She's our managing director here at the center. But we have expertise in education, public involvement, obviously design, engineering, and data science, and also behavioral sciences as well. More or less, our team is between 15 and 20, so fluctuates between those numbers. And we don't have a strong desire to grow it beyond that in the near future, to be honest. Yeah. We partner with very different organizations. So obviously, the UK research institutes, they're, funders, but also the National Health System. So the NHS also funds us. We seek funding from charities, but also from commercial partners. So I guess that this is going to be quite similar to many academic organizations. We just get money from wherever we can, and that's how we do it. Yeah. Our process, you will be familiar perhaps with the double diamond. So our process is not very different from the double diamond, but we've taken that as a basis and then modified it a little bit so that it fits the healthcare context and it fits our way of working here at Helix. You will notice that there is a big, here, I don't know if you can see my mouse, but there's a gray line that goes underneath double diamond and beyond, which we call PPPI, which is patient, public, and professional involvement. And so being user-led is what guides and defines us. So it's very important for us to involve patients and the public, not only in projects, but also in the planning of those projects, and so that they are part of setting the agenda as well. We also have considerations about when to start ethics application and how to go about research, which I'm sure you'll be familiar with as well, and when also to start other processes like quality management systems, for example, and go for regulatory support of that nature. So when we are entering the phases for feasibility studies or clinical trials, that becomes quite relevant as well. Right. So again, not to keep on beating the drum, but what we work with the people that we are designing for. So here is a few images of different workshops, interviews, and us involving the public. Sometimes in like very intimate scenarios. So for example, on the images on the bottom right and bottom middle, we go to people's houses and environments to understand how they live, understand certain conditions, or understand their experiences in whatever it is that we are trying to understand, all the way to shadowing people in hospital, etc., but also involving the people in public events like fairs. So for example, on the top left, we can see one of our interventions in health during the Great Exhibition Road Festival, which is an annual public festival of sciences and technology that is happening in Exhibition Road, which those of you who are familiar with London is where the National History Museum, the Science Museum, the Victoria and Albert Museum are. And so that road becomes open. Imperial College is also based there. The Royal College of Art is based there. That whole road becomes open and it's like an open science fair. So we invite the public as well to take part in some design in health activities as well. Again, you being designers, I take that is everybody here a designer? Am I right in assuming that? Okay, perfect. So prototyping is second nature to all of us, I suppose. So this, I'm not telling you anything new. We do this all the time, but we also involve the people who are not so familiar with this. So we provide a way of thinking in a different way to them as well and share their ideas in that way. Right. So this is a summary slide of some of the projects that we've been, well, not projects, like thematic research that we do. On the left-hand side, and on the right-hand side is some of the work that we do more closely with the trust. So these are the two main ways that we work in. So longer-term thematic research projects that are normally grant funded. And at the moment, we have 4 main themes and some other that are emerging. So rehabilitation is the theme that I lead. Then we've got a theme in dementia. We've got a theme in healthy aging, and we've got a theme on end-of-life care. An emerging theme is prevention as well, which, it's overlapped with this healthy aging one. But we also have a person that is leading a project on dance as a way to promote health and prevent ill health as well. So we have quite interested in that area. Then on the other side, with the trust and the NHS, we've been involved in many different projects. These tend to be a little shorter projects, so roughly projects that last between 6 and 12 months on the right-hand side, projects that go multi-year and multi-grant phases as well on the left-hand side. So that's roughly how we divide our work. But we also have that educational offer that I was talking about. So my colleague Alex Barkley leads. He's the head of education, and so he leads these initiatives. Some examples are the Digital Health Leadership Program, which is part of the NHS Digital Academy, which is a national project that was established to brush up the skills in technical leadership, or the knowledge in technical leadership for people at the driving seat in the health system. And this is with the aim of facilitating or boosting the plan for digitization and health, the transformation of that service into a digital service as well. We've also been leading the Healthcare and Design Masters and MRes program, which is a joint program between Imperial and the Royal College of Art. And this program recruits students who may have a design background or a clinical background, and puts them together into this 2-year course to learn about design and healthcare innovation in that space. Right. So onwards, these principles that we've developed in the past 10 years of being involved in this space. Just quick question to Jorge. How much time do we have for this? How much time do we want for questions and discussion? You're on mute. Sorry.
You are mute, Jorge.
Thank you. Sorry. In general, we plan this for 1 hour, which means between 30 minutes or thereabouts, or 40 for you, if you wish. And I don't have a 1 hour in the system. I put an hour and a half, but people normally plan for that.
Okay.
I would say if you talk for another 10 minutes, that would be great, and then we pass to questions and answers and whatever else.
Fine. Okay. I'll try to gauge myself that way. All right. So this is the summary of the different principles. So meaningfully involving users, working in multidisciplinary teams, building trust and empathy, developing themes around difficult subjects, and combining, the different expertises of design, behavioral science, and clinical academic rigor, and designing from the inside. So I'll break these down a little bit. So obviously the meaningfully involving end users throughout is the core principle of Helix. So that, as I explained before, can mean anything from involving people at the very start of when you're thinking about a funding application, for example, or entering a thematic area as well, getting those points of view so that we understand what are the pain points that we should be looking at, or guiding that research agenda is quite important. And we do this in many different ways. So there are many projects that create a board, if you will, of projects of patients and public involvement. We create steering groups. so that we can go back to those forums and check in as well as we go along, as we make progress. We check in back to with the members of the public or members of the community. We more and more are looking at making those forums as diverse as possible, and we really go as far as we can to help reach out to the people that normally are left excluded. We have very good capability with our colleagues who are experts in PPIE and developing new methodologies, developing new guidance, which I can share with you as well. There's a new website that they've just published about how to involve public and patients in your research and what things to consider. So yeah, I'll share that later. So for example, yeah, so here I'm talking about different projects in dementia on the images. So from developing urinary tract infection devices that need to be used at the home or at the point of care by members of staff, but also with the dementia person in mind, to other prototypes that we developed to support dementia care. So the one at the bottom right is a cardboard prototype at that stage. It has now evolved. But basically, during COVID, it was very difficult for people to join meetings online, especially if you have dementia, right? So we developed this solution that embedded a tablet within a cardboard-based stand. And we developed this application that only had a few cards of people that the person with dementia may want to talk to. And all they needed to do is like flash that card in front of the device. So it actually was like really well labeled to say like put the card here. And immediately by putting a QR code on the camera, it rang that person. And so you could have a conversation with them. So that's just an example. But in other areas here in dementia, there are different participants and a strategy to involve the public. So we have a lived experience group, which is formed by 16 different people who may be dementia sufferers or carers for people with dementia. So they have lived experience. We also have a Minder community. So Minder is the name of the project in general, which are participants in a smart home study. So we have a smart home space and people come there and test different projects or different devices that we're maybe developing. And then we have a wider network called the Friends of Care Research and Technology Team. And basically, this is a really nice forum for involving patients and the public in general in more like science-based research for dementia. So the team there have done like a really, really, really good job of involving the public. I'm going to whiz through these, but these are just some examples of how we iterate design based on the inputs that we get from clinicians, patients, and carers. This in particular is a report note on, I think it's sleeping data in this case. And so these are reports that go to clinicians or researchers, but the public have also guided on what type of data they are happy to share, etc., and how would this be visualized better. Then the working in the second principle is work in multidisciplinary teams where colleagues can translate across specialisms. So here we combine designers, clinicians, and public involvement specialists, behavioral scientists, engineers, and data scientists throughout our projects to build deep subject matter expertise within the group. So these images are from the rehabilitation theme. So a product that we've developed called On Track Rehab. This is a product made to support people after they had a stroke in recovering the use of their arm. And for this project, we've worked very closely with a wide number of people. On the image below, you can see 3 different expertises. Obviously, the person sitting on the chair is a stroke survivor. Then Claire, my colleague on the right-hand side, she's a behavioral scientist. And on the back end, we've got Matt, another colleague who is a machine learning expert as well. So combining all those expertises with design has led to the development of On Track. So also here in these images, we can see the involvement of therapists in guiding that. And also another time on this great exhibition Road Festival on the bottom image, we crowdsource data from the public to collect movement data so that we can train or validate our algorithms as well. So involving people throughout and different expertises as well. This project in particular is one of those that has like gone through most of that double diamond process that I've showed you at the beginning. This has been UKCA marked, and it's ready to be spun out. Actually, it's going through that pathway of being spun out as a company. And just to go through the details of what this product does is basically tracks the arm activity of someone who has had a stroke passively throughout the day and provides digital coaching input on how to move your arm, when to move your arm, but also has a clinician-facing interface so that support is there as well. Number 3, building trust and foster empathy when researching sensitive subjects. So we don't shy away from researching things that might be difficult, but we do acknowledge that some things might be quite difficult. And so we take extra time to build trust and empathy with the people that we're designing with. And so this means that the more engaged that people are with the research and understand why it's important, the better outcomes or the better results that we have in those projects. So, for example, for our cancer pathway transformation work, we were gathering insights from patients and those who support them. So it's very simple things that you might already think about, but offering different choices as to when and where they would want their interviews to be held. Participants were free to choose the locations and the times. We tended to host things in safe areas, so not in a clinical space or not in a research lab. We often use this Helix Centre, which is a cancer charity, and they have like really nice spaces to hold conversations for people who are undergoing cancer treatment. And sometimes we also interview with mental health first aider present, because if we're touching like really difficult conversations, it's often the case that people might be triggered or break down. And so signposting them to the right support is quite important and something to consider. Yeah, so again, developing themes around challenging subject areas. So our place in the university, working with philanthropists and charities, allows us to develop deep expertise and bring human-centered design important but less commercial on brackets subject. So for example, the image on the bottom is from a project we call Palliate, which is a project to support non-clinically trained carers provide clinical care and support to people who are in an end-of-life pathway and are being treated, or which their desires are to die at home. Often those people, when they have an emergency, the carer might ring 111 or 999, and they end up conveying the person to hospital because there's no other way. And so more often than not, that's their last trip, and they end up dying where they don't want to die. So with this project, we aim to support people in providing some care and training them through simple materials. And so this is a theme that perhaps funders are not super interested in funding this kind of stuff. We struggle to find funding apart from like charities or the like, but we don't shy away. So developing these themes we think is quite important, and still designing for those, even if like finding funding for those might be sometimes tricky. So yeah, again, on end of life, we have developed a few different projects within that. So one of them being the Respect form, which is a document that is now quite widespread here in the UK. About 70% or over 70% of NHS trusts are now using that form. And basically, it's a form that records the wishes and preferences for treatment on someone on an end-of-life pathway. We've also designed some experiences for families who are going through the experience of having a child in a hospice. So different things like designing gardens or experiences for siblings to keep in touch when it's difficult, that kind of thing. Then Palliate, which is the project that I just mentioned, supporting carers to deliver care at home, and then other inpatient experiences as well. So end of life is a quite rich and design needy area we've found. So there's a lot of things to do there, and I think it's very needed. Number 5, combining design, behavioral science, and clinical academic rigor. So our university setting allows us to get the best of human-centered design-led innovation, behavioral sciences, and academic frameworks. Exemplary projects here are the Healthy Aging Project, which we've been running for over a year now. And here we're looking at ways in which we can prevent or delay or reverse frailty in older adults. And we're doing this by equipping the environment where the older adult may live, but also where we're using wearable sensors. So we have a package of sensors in the body, in the space, that monitors the person throughout. And we have a coaching component as well in this project that helps people adopt healthy habits. So for example, that might be activity-based, like steps, for example. It could be preventing sedentary behaviors, monitoring sleeping patterns, but also a little bit less straightforward to measure through sensors, understanding what their social patterns are and how things might be changing as the person ages and how that correlates with markers or traditional markers of frailty, like outcome measures, clinical outcome measures. Yeah. So
I would like to propose something.
Yeah.
Because you have gone through 5 of your 10 items.
It's 6. There's one more, so we can go to the last.
Oh, is that right? Okay. Then go to the last.
Okay. So yeah, the last one is design from the inside, and I think it's relatively straightforward for us. So we are doing more and more of understanding deeply what the trust might need, and we design with them from the inside. So making things better for our trust can then help us look outwards and do an exemplar here that we can then scale. So in the past, we shied away from doing like pet projects for the trust because they were not scalable, or we thought that might not be scalable. So we now have a way or a process to judge whether a problem in the trust has a potential to scale. And so those are the types of projects that we tend to prioritize as well, and we're guided by the NHS agenda as well. This is one little sample of a project that we did in a project called Equity in Outpatients. So basically explaining how we wanted to reduce the incidence of did not attend to hospital appointments. And through our research, we saw that specific ethnicities and deprived areas tended to form up to 50% of the people who, or were, 50% more likely to miss their appointments. And so we focused on tackling the problem from that point of view. Yeah, then another one is this project called Touch Dose. This is one that is no longer sitting at Helix. This project actually became a startup maybe a couple of years ago and is now out there, but basically started as a problem that we observed here in the hospital. And this was the problem of providing emergency medication to children. It's quite difficult to do that because in an emergency situation, especially because it's all based on weight and size of the children. So the doses are based on that type of parameters. And so often there are medication errors that tragically end up in bad outcomes. And so this team developed a digital solution to estimate weight and size to provide a dose, but also to remove the cognitive burden from staff in those emergency situations to do which things that might be like simple maths calculation, but in a stressed environment becomes quite difficult and quite prone to error. So this thing has helped them improve that. So that's it. Sorry, I had to like rush through
No,
it.
no.
Yeah.
No,
Um,
sorry to put pressure on you, but
no, that's fine.
you had provided a hell of a lot of information about your entertainment. And I would like to offer some opportunity for people to ask some questions, particularly the three visitors, Denise, Will, and Carol, and is Andrea? Or yeah. Okay, so shoot.
Andrea, go ahead.
Thank you. That was a really clear presentation. It sounds like a brilliant place to work. Very jealous. Yeah, I had a question about you're talking about combining design with behavioral science. And I just wondered if you could talk a little bit about how you bring together methods of design with methods of behavioral science. Because I work with a behavioral scientist on a project, and we've kind of struggled, I think, about how we bring our different methods together. So yeah, it'd be interesting to hear how you
Okay.
do
Yeah,
that.
no, great question. I'm not sure where, yeah, maybe if you can clarify a little bit, like where is the competing interest or where is the clash that you've been seeing? Because I think that we complement each other really well, but maybe, yeah,
Um, yeah, not so much a clash, I guess. There's definitely some overlap. So it was thinking around methods like the COMBI framework, behavior change frameworks, and behavior change wheels and behavior change techniques, and then how these sit along like traditional design methods where you've talked about needs. So you might do your, you
yeah,
know, kind of research into lived experiences and needs, and then how these kind of
yeah.
findings all come together to inform a design or a
Great.
design
Yeah,
process.
perfect. So I think that that exemplifies exactly where design might more suited to lead and then where behavioral science can take over as well. So I think that we are really good at really understanding the context and understanding the behavior that currently exist. So going there and doing the ethnographic research and really understanding, what are the issues, providing our themes and maybe design principles or design requirements, and then adopting the frameworks of behavioral science for making a change on those behaviors. I think that that's where the overlap and complementary skills lie. So, the frameworks that you mentioned, the COMBI, for example, I find that are excellent frameworks to once you've observed that behavior that you want to change, you can adopt that method so that you can instill and then maybe adopt, like understand where you could design an intervention to support the combi, for example. So is it in facilitating an interview or creating materials for both parties? If it's like a two-party interview, to be prepared for that interview or for that touch point, essentially. I think that there is like a lot of overlap and complementary skills. Not sure if that answered the question, but yeah.
Yeah, no, it does. No, it was interesting to hear your experiences on that. Thank you.
I think Will may have had his hand up first. Yeah.
Hi, thank you so much. That was really, really interesting. Um, I think my question is about you talk a lot about kind of user-centered design and involving people, which is really lovely to hear. I just wonder how you balance the different needs of, well, you almost have quite a lot of different user groups there. Obviously, you talked a lot about patients, which is great. But there's also, I suppose, the doctor's perspective as well, and you must involve those. And then there's kind of like hospital management as well. And then there's kind of almost like a business side. It sounds like you're spinning out businesses. So I guess is your aim to kind of find a sweet spot where there's something which benefits from all four different directions, or how do you kind of balance those different needs with each other? We won't talk too much about how much hospital managers and doctors argue about things, but there must be some tensions there that you're having to overcome.
Yeah, I mean, I think that this is like quite a common thing for any design project, not just in healthcare, but you will have like multiple stakeholders and you need to balance the needs of all of those. I think that we do tend to prioritize, if you will, when we are, when we're delivering healthcare, the patient needs to be at the center. So we do prioritize those needs, but then equally, if we create a solution that clinicians won't adopt, then there's no point in it. So we do try to bring all perspectives to the fore at different points in time. But I think that the patient perspective may be the one that trumps them all. But yeah, I think it's quite a delicate and balanced thing that you need to do little by little, trial and error, I suppose. Yeah.
It's my turn.
I guess so.
Okay, thank you very much, Gianpaolo, for your presentation. It's really, really significant for me because I'm based in Chile, and at Universidad Católica, we are in the process of formally establishing an institutional design and medicine program.
Nice.
So the Helix program is quite an example for us. And my question for you is how to start, because right now we have a lot of experience that has been developed by individuals that are passionate and have, gone together to, create amazing projects from the most tangible to the intangible disciplines of design. And now we need to put all that together. And I would like to know what your experience was in, putting this center together.
Yeah, that's a great question. And man, I don't know if I have like a answer to it, but I think that I can have some like suggestions or inputs. It's interesting that you are saying that you're trying to do this in the Universidad Católica in Chile, because we've been collaborating in the past more than recently, but we've been collaborating with the UDD in Universidad del Desarrollo.
I know.
Because they also have like this desire of having like a similar thing to Helix. So I've been there. Yeah, I was there once or twice. I can now not remember. Maybe once only. Trying to help them as well set something like this up. I think one of the keys is to really be multidisciplinary in that nature and have like senior leadership buy-in. So from a clinical point of view and design, but also have like understanding of the strengths of each other. So I think it's very important for the clinical side to really, really buy into and understand that design also has a seat at the table. Because without that, then it just becomes I think that it becomes less credible, of course, from their point of view. And it's really, really important that they have this like understanding that there is a way for design to have an input in there. I think, yeah, I think that that's the main thing. If you have like the design expertise without the clinical expertise, I think that you're out, So I think it's important that you have that clinical buy-in and really strong partnerships. Yeah.
Okay, thank you very much. And another question, may I visit? I
Yeah,
would like to.
anytime. Yeah, you can come. Yeah.
Jermina, you have the hand up.
Yeah. So, and I can connect it to the question of that Denise had. So you were talking about the need to help people understand how design contributes.
Yeah.
And I think that something that is very important is to help people understand that design contributes not only by designing products. Otherwise, they come to the designer, can you design the website? Can you design the app? Can you design? So they already know what is needed, when in reality, most of the time when we engage, there might be many other things that need to be designed, like a service, for example. Few people have a service in mind. So I wonder if you sometimes manage to focus, your presentation was focused on product, but managed to focus more on what the product might help achieve, like a very different healthcare conversation or a very different healthcare pathway, or reducing the stress of physicians or health providers. That is one of the biggest problems, for example, in Switzerland right now.
Yeah.
So that's my question. Can you sometimes go further than the product? Because I think that focusing on product limits what healthcare providers understand of how can designers contribute.
Yeah, no, that's an excellent point. But just to piggyback from what you were saying and to complement my what Denise was asking, I think completely. So I think it's important as well for the buy-in from the clinicians not to expect immediate solutions. So that's a thing that I think is sometimes at odd with what designers can bring into the mix. So yeah, often clinicians will come with, like, as Guillermina says, like a request for something, for a solution. But I think, yeah, you need to give space to understand first, where is the problem? Is there a problem really? And what might be the best way to solve that, rather than, I need a website, because I think that from my observation, the website is what will solve this issue. No. So I think, yeah, yeah, spot on, I think, Guillermina. From our point of view, and to answer your question, I think a lot of what I showed here not necessarily started as a product, but evolved into that. So I think that we do a lot of that understanding, that first bit of the double diamond. We spend quite a long time, and even before that, as I said, like involving the people in setting the agenda for what it is that we need to be looking at, not even like solving. We don't know if there's a problem there even sometimes. And so, yeah, I think that the thing, I sort of like have a thing with this design thinking phrase, or this mindset, as saying that design is, everybody can do design thinking. I think, yes, maybe in a way, but yeah, I think that you need the design expertise to go through not just the thinking, but also the execution bits of it. So, but yeah, just to say that we do that bit, so that bringing that thinking and using design as a strategic tool, not just as a product delivery tool. Yeah.
Andrea? You're
Hello
mute.
there. Oh
Okay.
yeah, thank you, thank you. Yeah, just a couple more questions. They're silly questions, probably not very profound, but I'll ask them anyway.
You're allowed.
Thank you. So in your slides, you talked about human-centered design and co-design and design thinking and design-led and co-production. And I suppose the first question was whether there is an overall, like, one methodology that you're working to, or do you just use like these different are you using these terms a bit interchangeably, or using them at different times to refer to different things? And is there one methodology that you would say is your umbrella overarching? And then the second question, you'd mentioned a website about PPI, and I'm just wondering if you know of any guidelines for paying clinicians, and if you pay the clinicians that you work with, and yeah, that would just a practical question, I guess.
Okay. So the first one on the interchangeability of the terms, I think me personally, probably I just interchange them. But I mean, in general, I mean involvement of the stakeholders, whoever that might be, in the different stages of setting the agenda, as I said, doing the research, doing the designing or the prototyping, evaluating that. And maybe for some of those who are more pedantic about terminology or more academic, there might be different terms for those different types of involvement, but in general, I use them interchangeably. Then you asked something about methods, and if we use them, how we use them.
That's it. That was it. You've just
Okay.
answered that question. That's grand. Now the other one was just a wee point about paying clinicians. So I know there's the NIHR guidance around paying members of the public, patients and public. I've just not seen anything around clinicians or professionals, if there are any existing guidelines you're aware of.
Yeah, no, we use those that they used to be called Involve guidelines. I think that they changed the name now. We use that, and depending on our ethics and depending on how the project is being set up, if we're not recruiting through the NHS, then we adopt the same Involve guidelines and we offer that payment as well to professionals. If we are being if we are recruiting from the NHS, then that means that we are HRA regulated study. So we have like rec approval and that kind of thing. Then that means that the project has means to paying so through the SOICAT. Sorry, this is very technical and a lot of like
I'm following you. We've done in NHS ethics as well. No, you've just answered it as well. That's brilliant. So you basically apply the same payment rates that you would apply for public and patients to professionals, to clinicians, if it's a non-NHS route.
Yeah,
perfect. That's really helpful. Thank you.
So because we treat them as like patient and public involvement, or we say PPP, so three. Professional, patient, and public. So they would be professionals involving in research. So we pay them with the same amount. Yeah.
Thank you.
I didn't put my hand up, but I will ask a question. I'm interested in your picking up a project you consider one of the best, one of the ones that you love the most, and tell us which is and why is that you are so.
Okay, I'm very biased, of course, because
of course.
Project that I lead, so there's been this project that I led on stroke rehabilitation, the On Track project. That's really close to my heart. So obviously that's my favorite project. But if I exclude that, that's a very good question. I'm trying to think. So
you don't need to exclude it.
Okay.
No. Yeah.
Don't exclude that. What I'm interested is why you pick up that as the one that you love so dearly.
Okay. I mean, I think there's multiple reasons. So one of the main reasons why I am so in love with design in healthcare is because of its potential for social good and generating impact, etc. And that's one reason. I think a lot of our projects do that anyway. But then there's the personal level as well. My dad had a stroke, and he was quite affected by it. Not just him, but us as a family as well. We're really, really, really affected, and so our lives changed from one day to the next. And so I think that is a further point of motivation, trying to make things better for people who have the misfortune of going through that. And then I think another one personally, in like a career sense, is that there's so much potential for involving design methodologies because it's so bad at the moment. The pathway is so bad that there's so much opportunities. But also from a technology point of view, there's a lot of scope for developing interesting projects in that way as well. So I think that there's multiple levels that satisfy me in that. And now that we're going through pushing it as a startup as well, that's an area that I'm not very familiar with, but I'm very keen to learn about that, commercialization and business development side of things. So I think that's why, it's quite a broad range of things that it's providing to me. Yeah.
Okay, thank you. Any other question, anybody here?
Yes.
Yes.
I think we touched slightly on language, which is such a delicate thing. I love Gregory Bason, and he used to say that language is pico-epistemology. And we are at the time where we use words but mean different things. Sustainability is an example. And so Andrea was also asking about human-centered design. I used to call myself, when I was in the Faculty of Medicine, a human-centered designer. And then I needed to stop using the term because a lot of people were criticizing the term, but also what I was doing, because of simplifying people and taking people as users. So reducing them because of being an anthropocentric term. So now there are all these terms that are used beyond human-centered design, more than human-centered design, humanity-centered design. So how do you deal with that? Do you have the same experience? Are you also being criticized, or is it okay? What's your experience with that?
Yeah, I think so that there are some moments where that might be criticized. My answer to that, or my sentiment to that, is that it doesn't matter what we call it too much.
Mm-hmm.
It's more about what it means and what it is, that
Mm-hmm.
it's what it's here for. And I think it would be, I want to choose my words carefully, but it'd be a bit silly for us to say that human-centered design is all about humans in a
Mm-hmm.
selfish way, if you see what I mean.
Mm-hmm.
So I think it's more about, the whole ecosystem and the planet, really. So
Mm-hmm.
if we do something that harms the planet but seemingly benefits the human, then it's not human-centered design, because in the long run it will harm us, right? So I think, yeah, when that debate comes up, I always like try to tune out a bit, because I don't care what we call it as long as the sentiment and the outcome is the right one. Yeah.
I think that the most important thing is not to reduce the reality, not just people, but not to simplify a reality. And so as long as we have the lens that a person is not just a patient, or is not just a mother, or is not just a physician, but it's a combination of many things, then we are okay.
Yeah.
Can I ask a last question?
Sure.
Gianpaolo, I just loved the way you put in your methodology ethics as a question. At least for us, ethics, when you had to go through the ethics committee, it's just a burden for design. It takes so long, and sometimes they just don't understand what we are trying to do, and they need everything to be just, exactly as it will be, like the design intervention. And we work with uncertainties. And we love that, and we embrace that. So that's not very compatible with ethics committees. And I wonder how you make, those questions, and how that at the end, makes you take your ethics decisions in terms of design.
That's a great question. It's a very good one. And we debate this, and we, struggle is not the right word, but we like constantly question these kind of things. I think, to give you a cheeky answer, we try to do as much as we can without. But because we have like good principles and values, we always take, a responsible approach to that. So the more that we can push it forwards, the better. Because, yeah, as you say, it's time consuming, and sometimes it can be limiting. What we found is that depending on the type of project that we're doing, and here in the UK it might be different than in Chile, but we have different regulations as to how we can class things. So we can have, like, if we're working with the hospital, for example, we could have what we call an improvement project, like a quality improvement project kind of thing, that doesn't really need an ethical approval. But if we're outside of the hospital, or if we do not need NHS ethics, for example, we work very closely with the college research governance team, and so we are in constant contact with them, saying, will we need to do an ethics application for this, yes or no? And so they always come back with, like, well, they ask more questions, and so we at the end iron out, do we need it or not? Yeah. But, another thing, maybe a bit cheeky as well. So if you already have, like, if you form your PPIE groups, and it's like a long-term relationship that you have with them, you can also do a little bit of work with them that doesn't require, because you're already covered by that. So we do a lot of user testing, for example, with our PPIE groups. And so it's a way for us to facilitate some things. Obviously, if you want to have like more generalizable results and research, then you will need to go through ethics.
Okay, thank you very much.
Guillermina, you wanted to say something?
Yeah, I have had very good experiences with ethics board, where actually they are helping me to think how to come better involved with patients because they have more experience on, for example, pediatrics or patients with diverse conditions. So I think that it really depends on the ethics board and the person on the ethics board, but they can also help you to think a lot. So again, what we were talking before, combining of expertise. So when and how, it really depends, which is a classical answer of designers, right? It depends. So they can be really good in helping you think through what will happen and how to engage with people and work with them in a way really that there is mutual learning.
And I think that maybe sometime we'll ask you, Gianpaolo, to come back again and answer the questions that we didn't have time to ask.
No, feel free to email me
Yeah,
anytime.
but like in design, one thing that Guillermina and I got used to is not to talk about design solutions, but talk about design responses. Because design problems, particularly when dealing with people, people are very complex and you cannot solve the problems. We have a huge problem with family violence in Switzerland, and you cannot solve it. You might be able to reduce it, you might be able to maintain it, hold it, but solve it is like I work in traffic safety. Impossible to do the zero objective that at a certain point the Swedes decided to have. People are going to keep on harming themselves. And in this case, we are not looking at you to give us the answer. These are topics that are being tossed about by us because we are interested in trying to understand further the kinds of things that are involved when you intervene in reality to do something that intends to change it. So don't feel cornered.
No, I think that's a very sensible. That's great. It's exactly. So,
but yeah,
by one brief, yeah. Sorry, go on.
We might ask you to have another conversation
Yeah.
sometime later, not too soon, where we have time to sort of mull over this set of things that you said, possibly look at the video more than once, and we'll let you know. But it has been wonderful. I thank you very much for your generosity in preparing this so well, filling it with content, and keeping us alert for this time that we were here.
No, thank you for the invitation. Yeah, thank you so much. Yeah, really enjoyable.
Everybody agrees. We stop the recording, yes? Yes.